So our topic tonight is cranial conundrums, clinical pearls for intracranial disease. My name is Dr. Joe Sowka. I am a provider at Center for Sight USI, and I'm here with my partner and co-owner of Optometric Education Consultants, Dr. Greg Caldwell. Now, these are my disclosures. In the past 24 months, I have been advised, consultant, or spoken. All disclosures have been mitigated. I don't have any financial interest in anything we may mention. I created this content myself, and as I said, with Greg, I am a co-owner of Optometric Education Consultants. Some other further disclosures I wanted to give you. I work in a large medical surgical practice, much like yourself. I'm not an academic referral center. I book 25 to 30 patients a day, primary care, glaucoma, corneal disease, emergencies, contact lenses, and I do the neuro-ophthalmology in our practice. So I function pretty much as everybody here does today. I don't have 2 hours to do a neuro-op evaluation. It's moving quick, thinking quick, getting the patient diagnosed and into the right hands. So we're going to start with a 60-year-old male who presented urgently for a visual disturbance following what he described as a severe migraine. He went to the hospital emergency room. They did a non-contrast enhanced CT of the head, which was quote-unquote normal, and they wanted to go further. He refused an MRI and left against medical advice. He developed double vision suddenly, mostly horizontal with a vertical component. He has extreme head pain in the right periorbital region, really on the right side, right behind his eye. It happened all rapidly, and the double vision developed 1 day after his headache and periorbital pain developed. Neither getting worse, neither improving, it's all constant. He has no fatigue, no vision loss, no nausea, no vomiting, no malaise, no lethargy, no mentation changes, no confusion. He has no primary care physician, and his blood pressure is 164/84. Here are his visual fields. He is 20/20 right eye, 20/15 left eye. He complains of no vision loss. Optic nerves and retina are normal with about a 0.35 CD ratio. Now let's take a look at his motilities. Okay, he moves to the left well. Now we can see he has an abduction deficit in the right eye. Otherwise, he is moving fairly well. Now let's look at his other video. Now we can see he has a significant vertical heterophoria in the right eye as well. So it looks like we have 4 and 6 involved. It looked like he had a little bit of upgaze paresis as well, so probably a partial third included as well. All right. So that brings me to polling question number 1, Greg. What is a likely etiology? Does he have a mass lesion? Does he have an aneurysm? Does he have ischemia? Or does he have inflammation? So what is our likely cause here? Oh, people are jumping into this really quickly. Greg, I've never seen it move so quickly.
How about it, huh? Experienced webinar meeting people.
Does he have a mass lesion? Does he have an aneurysm? Is it ischemic or is it inflammatory? All right. I think we're pretty good there, Greg. If you want to end it and share.
Okay. You able to see it, or can you not see it?
I'm always able to see it.
Okay. So the polling question is 14% says mass lesion. Aneurysm is 39%. We have 33% saying ischemia and 14% saying inflammation.
Excellent. Yeah, and these are all things that are very reasonable considerations. Well, what do we need testing? Well, we need brain, orbits, and chiasm with gadolinium and fat suppression for the orbits on the MRI. We need sed-rate C-reactive protein platelets for giant cell arteritis. We need acetylcholinesterase antibodies for myasthenia gravis. And this is all in descending order. What's most important is the neuroimaging. This is my order that I had written up. 6 nerve palsy, and so I can only put down one diagnosis at a time. Stat, attention to right cavernous sinus, paracellular area, rule out aneurysm, cavernous sinus and posterior orbital inflammation, pituitary apoplexy, contrast both brain and orbits, and fat suppression for the orbits. Now, I had difficulty getting the MRI scheduled between the patient and the imaging center. And turns out, like the first available that the imaging center and the patient would agree to was 2 weeks, which I didn't find acceptable. So I find myself, I'm playing radiology, let's make a deal. And I finally got it moved up to 48 hours after negotiating with both the center and the patient to make me happy. And this is what comes back. He has abnormal enhancement of the orbital apex, mostly his right superior orbital fissure. They do notice the esotropia. Infection is possible, but unlikely given the lack of other inflammatory changes. Tolosa Hunt is the working diagnosis here, but is a diagnosis of exclusion. Neoplasm is possible, but that's less likely. We could MRA of the circle of Willis. And follow up in 1 to 2 months. They, let me know what the results are. And our working diagnosis here is Tolosa Hunt syndrome. So the inflammation, the pain, the presentation really is consistent with Tolosa Hunt syndrome. But I will acknowledge he does need more evaluation, including CT of the chest to make sure we're not dealing with a neurosarcoid. But because this was so painful and distressing, I worked in Florida, Greg. I don't have oral steroid privileges, so I worked with a retinal specialist, and he wanted to support me and help the patient. But as he said, he never diagnosed nor treated one of these before. But we together started him on 60 milligrams of oral prednisone, which made him feel better pretty quickly, but the diplopia still persisted. The challenge, Greg, in these Tolosa Hunt syndromes is they're really difficult to do a steroid taper because it can rebound. And because of all this, I felt that I wanted to work with somebody who has a little more experience in the taper of these steroids in this condition. So I worked them in. I have a very good relationship with neuro-ophthalmology in my area. As a favor, they agreed to see him within 48 hours, and of course, the patient was a no-show. And his response: "I've got a business to run. I can't be taking off to go see doctors." And sometimes you just want to tell a patient, "I am trying to help you." What is Tolosa Hunt? It's a severe unilateral periorbital headache associated with painful ophthalmoplegia. It's recognized by NORD, which is the National Organization for Rare Disorders, as 1 case per million. So he's literally 1 in a million. And it's an idiopathic inflammation, the cavernous sinus, superior orbital fissure, not associated with any systemic inflammation, infection, or autoimmune disease. And if this person were amenable and agreeable, I would be working with a rheumatologist on this as well. Now, the International Headache Society has a diagnostic criterion for Tolosa Hunt. It's a unilateral headache, which includes granulomatous inflammation, the cavernous sinus, superior orbital fissure, orbit, as seen on MRI or by biopsy. Palsies of 3, 4, and/or 6 on the same side, happening usually within 2 weeks of the pain, or they usually happen simultaneously. It's localized to the head and the eye on the same side, and frankly, there's no better explanation for the headache. Now, in these patients, they have dramatic improvement in pain with oral steroids. Now, the ophthalmoparesis is a little slower to resolve, and indeed, it can spontaneously resolve, but it has a tendency to recur. Really, there's no specific information about dose duration or route of administration for these steroids. Usually, they're high-dose oral steroids for a few days, followed by a gradual taper, but these patients have a tendency to rebound, and the steroid taper can be very challenging. So, Greg, is there anything in the chat box for me?
I got the chat box working. That's good timing. There are people now saying thank you because I welcomed everyone. Questions. We had the person coming in from Hawaii, so that was the reply.
Excellent.
And the
Aloha.
last one is, can you quickly go through the initial differential on the polling question?
Yeah, initial differential, mass lesion, things don't happen that quickly. Aneurysm that could affect 3, 4, and or 6 is really only going to be in the cavernous sinus region, this internal carotid artery. We're not dealing with one of those killers from third nerve palsy. Ischemia does not give us multiple cranial nerve palsies, only one at a time. My first thought was this was inflammatory due to the pain and abrupt nature. Now, here's one post-op red eye. I was on call.
Hold on
Oh,
one
yeah.
second.
Mhm.
Could you have diagnosed without an MRI?
No. No, you need to make sure that there is inflammatory material in that orbit and or cavernous sinus. You need the imaging.
Is color vision affected?
No, his optic nerve is not affected. All
You
right,
are caught up.
post-op red eye. 73-year-old male, cataract and mild glaucoma, undergoes cataract extraction with an eye stent the day before. I'm on call, so I get an emergency call at 6:30 in the morning. He's like, geez, the office opens at 8. Can't you wait a little bit? So I listened to take the patient's call. He said, I woke up and my eye was all red. I really can't see. Now, what I have learned to do is I will not do anything without a picture. I usually tell patients, take your phone out, take a picture, text me a picture, and let me see. Person wakes up post-op red eye is red, probably maybe a corneal abrasion, can't see, might be some corneal edema. And he looks like this. And this is pretty good for a selfie, or maybe his wife took the picture. And what you notice here is probably, he just got up, so we can tell how he's sleeping. You see the hyphema here, probably about 40% of the anterior chamber. Now, he did say he really couldn't see at all when he got up, and it was beginning to get better. So the hyphema is probably beginning to drain. And you can see the vasculature, the redness compared to the. So, Greg, that brings me to polling question number 2. This is not a problem because hyphema commonly occurs after eye stent. It's not a problem because blurred vision is probably from corneal edema. It is a problem because the lens probably dislocated, or it's a problem, but I'm not really sure why.
Looks like you're caught up on the questions.
Excellent.
I did not put the handout in the chat yet. Thank you for the reminder, Vanessa. All right.
I think we can probably call it here.
Looks like they're rolling in. All right, we're going to end it right now. All right.
Mm-hmm.
So I'll share the results. And 18% not a problem because hyphema commonly occurs after eye stent. We got 7% not a problem because blurred vision is from corneal edema. 14 a problem because the IOL dislocated. And 62% the winner is it's a problem, but I'm not sure why. And Joe, that's why they're here.
And that's a good answer. I like that. I kind of knew exactly what happened as soon as I saw the patient. And it comes down to, hyphema does occur. In fact, Greg, I had a hyphema today after an eye stent on a 24-hour post-op, but it was just a little micro hyphema, not 40% or not more than that. So it's not the question about how red is the eye, but how is the eye red? Look at the right eye and look at the left. And what do you see about the vessels? You've got that dilated tortuosity. You have clear intervening conjunctiva. And this has a very characteristic appearance. I knew it as soon as I took a look at it. And what we're dealing with here, and this is another patient, is a patient with a low flow carotid cavernous sinus fistula. And this is a CT of another patient where you can see the dilated superior ophthalmic vein. Now, the cavernous sinus is this trabeculated venous cavern, which has some pretty important neuroanatomic structures in it. It has cranial nerve 3, 4, 6, first division of of the fifth, the oculus sympathetics, and the internal carotid artery. And what it does is it drains the eye and adnexa via the inferior and superior ophthalmic veins into the petrosal sinuses and out through the jugular vein. A fistula is an abnormal communication from one structure to another. It's a rupture of the internal carotid artery or the meningeal branches within the sinus. So the meningeal hypophyseal, mecanalous capsular artery, the inferior cavernous artery, and you have arterial blood mixing in the venous system. So here's what happens. This is the cavernous sinus. This is that trabeculated venous cavern on each side of the sphenoid. And blood from the superior and inferior ophthalmic veins drain in here, drain out through the petrosal sinus into the jugular. We have the internal carotid artery, we have cranial nerve 3, we have 4, we have B1, we have 6, we have B2 kind of in there. And blood that is supposed to be going this way is backing up because this is very high flow arterial blood, pushing it backwards in this valvulus venous system, causing the orbital congestion. And you can have a rupture of the artery itself, or more commonly, one of the smaller branches here. And interesting, Greg, I found this picture on the internet, and it looked really familiar. I think this may actually come from one of my absolute first publications that I ever made, this image here.
Very cool.
Now, what happens with iStent? iStent is a trabecular bypass. It is allowing aqueous to flow through the meshwork into Schlemm's canal, into the aqueous vein, the episcleral vein, venous system, into the ophthalmic veins. Now, what happens is, if blood is high pressure going this way, what goes on? Glug, 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 glug. Blood is now accessing the anterior chamber. So we either accidentally put a iStent in an eye with a cavernous sinus fistula that was undiagnosed, or more likely, during the surgery or after the surgery, the patient developed a fistula and now had a route to get into the anterior chamber. Now, these are categorized hemodynamically: high flow, low flow. Either the artery or one of the branches will leak. Angiographically, either the artery itself or one of the small branches. Or did it happen as a result of trauma, or did it happen spontaneously? This is the high flow rupture of the internal carotid artery. These are people who have had severe head trauma. The ones we're more likely to see are the small leaking branches of the internal carotid artery, or sometimes juxtapose the external carotid artery. Now, this is a patient who has had a traumatic issue. This is a rupture of the internal carotid artery. What we're going to be seeing are patients like this: dilated corkscrew vessels, clear intervening conjunctiva, omega loops where the vessel goes into the limbus, turns, and comes back out. This is a traumatic rupture of the artery. This is usually a spontaneous rupture of one of the small branches. Now, fistulas are going to have increased venous pressure, obviously, orbital congestion because everything is now flowing retrograde the wrong way. The traumatic ones will often have a pulsatile proptosis. The low flow ones tend not to. If they are proptotic, you can have corneal exposure, but what you're looking for is arterialization of the episcleral and conjunctival vessels, those dilated corkscrew vessels that really have that clear intervening conjunctiva. The patient may actually hear their own heartbeat in their eye or their head. Very common to have myopathies and cranial neuropathies because of everything that's being involved with subsequent diplopia. And these patients can develop a nasty secondary glaucoma due to increased episcleral venous pressure. Everything is backing up and heading toward the eye. Now, these are vision threatening, but they're generally not life threatening, although there have been some reports of patients developing a fatal epistaxis and bleeding out through their nose, but that is very rare. These spontaneous ones, as they come, so shall they often go. They often resolve spontaneously. It has been recommended that these patients, if they have a low flow fistula, start to compress or try several minutes of gentle compression of the internal carotid artery with a contralateral hand. If you are disturbing the flow, you can actually have one of these small little ruptures kind of self-seal. Nowadays, they're usually going in with a stent, and they'll actually stent the vessel. They can maintain the internal carotid artery, and they can block off where the leak is. So this is often going to be done with endovascular treatments today. The glaucoma that develops, it needs to be managed aggressively. Prostaglandin analogs are about the only medicines that really work because they work independent of episcleral venous pressure. So here's a rule: beware of the chronic red eye. These are people that can have a condition like this for a very long time. You're looking at dilated and tortuous episcleral vessels that go to the limbus and back, what we call these like omega loops. And it's not an infection or inflammation because they have clear conjunctiva intervening between these arterialized vessels. And they're often, people come in with red eyes that don't respond to any topical treatments. They have 2 antibiotics, 3 steroids, 2 antihistamines, and 5 artificial tears, or what I call bag o' meds. Greg, anything in the chat room for me?
You do have a question that says, please define intervening conjunctiva.
All right, let me go back and just show you a picture right here. You see how the vessels are red? You see how the vessels are dilated here? But look at the conjunctiva, everything between it. You don't have any small vessel involvement. Not like you have an episcleritis or a conjunctivitis or even a corneal infection. You don't have all that redness. It's very, very distinct of the vessels. Good question.
How would you manage a quiet, it just moved, hold on, a quiet eye, but a patient says they feel their heartbeat with lifting and straining?
I don't know if I have an easy way to say that. I don't know if I have anything like that. That's probably just a Valsalva maneuver. I wouldn't do anything about that. I don't think they have fistulas.
What are instructions for ICA compression time frame?
We usually tell them 5 to 10 minutes of just compress, stop, compress, 10 seconds, stop, compress, alternate hand, because if you're cutting off the blood supply of the brain, that happens, their hand's going to drop. It's not going to kill themselves, so to speak. For about 10 minutes, and try that because you just want to create some irregular blood flow that might help plug things up.
Is there a higher risk for it happening to the fellow eye?
The answer is no. I mean, there is some risk. They have found little aneurysms on these small vessels in the fellow undisturbed eye. So there is some risk, but I can't say it's going to go one to the other.
Are those dilated vessels normally 360?
No, they don't have to be. They often are. Depends how long they've been there, but they don't have to be.
What is the workup? Carotid ultrasound? Question mark.
I would recommend CTA or an MRA. but tell them what you're looking for. And as I did, I had very little involvement with this. This was in our practice. I called the surgeon who did the surgery. I called the optometrist who was co-managing and said, think we got a fistula here, guys. Here's what needs to be done. Good luck.
And with that being said, a question was, what was the outcome of this patient?
The outcome, I don't know. I unfortunately did not follow through on that one. But my belief is it probably sealed up, or they got him to a vascular surgeon. All right.
Great.
I'm going to move on, if we can, to a 52-year-old male, and there will be a series of patients in relatively rapid succession here.
One more question. I think this is important.
Sure. Okay.
Is this urgent, like a stroke issue? ? Hospital ?
Good question. The answer is no. It is not. It is not urgent. I would probably do this outpatient to figure out what it was to make sure I was indeed correct, and then I would reach out to a vascular surgeon with my diagnosis. But it is not a stroke. It is not a hospital referral. All right, 52-year-old male. Last eye exam 2 years ago, no dilation. He knows he's got a peripheral blind spot in his left eye worse than his right, mostly when he's driving, trying to look out the side view mirror. No change overall in acuity other than issues with driving. Glasses don't seem to help the blind spot. He has 20/20 in each eye, no afferent defect. Examination is normal, 0.2 CD ratio, pink and distinct optic nerves. And this was seen by another OD in my practice in another office, and she ran a screening visual field, 120-point screening, and came up with this. And she said, asked me to see the patient. She said, I don't feel comfortable going any further. Could you help me out? And of course, I'm glad to. So she referred the patient over to me, and the first thing that I'm going to do is a formal visual field, and I want you to not look at the total and pattern deviations as we've been taught. What I want you to do is look at the grayscale. What we can see in the grayscale, he's got a left incongruous hemianopic defect. And we can see it's worse on the left. We can see why he has difficulty driving and looking to the left. So this is a patient that we need to get prompt neuroimaging on, brain, with and without contrast. Orbit is not as important to me here. And he comes back with a suprasellar mass compressing the chiasm, displacing the midbrain. Differentials include macroadenoma with infarction, which is a pituitary apoplexy, but he had no headache. Epidermoid cyst, cranial pharyngioma, and he also has some mild hydrocephalus swelling of the ventricles. Ultimately, he underwent a craniotomy with a near complete removal of the tumor. I did lose him to follow up, but his wife called twice and left a message thanking me for finding her husband's brain tumor. So here's a clinical pearl. My picture up here of the iPhone this is a resource slide. If you want to take a picture of the screen, now is the time to do it. Here are some pearls. Full field 120-point screenings are not helpful. Don't do them. They don't do anything for you. 30-2 is no better than a 24-2. You don't need the extra points. CETA standard is not needed to use a fast or a faster program. NeuroOp is not subtle. You're not looking for an early glaucomatous change here. A faster program is okay. And please look at the bloody grayscale. It helps identify neurogenicity in the visual field. 68-year-old male in our practice, has cataract surgery, has a little capsular haze afterwards, undergoes a YAG. He comes out 20/25 each eye. And I have clipped in here from the chart, vision is worse now than before my surgery. Bright lights bother me. I'm missing letters when I read. This was all written in caps, so I have to assume that he is yelling at the tech. He feels that his surgery was botched. Now, the co-managing optometrist in our practice examines him, can't find anything wrong, refers him to our retinal specialist, who finds a few retinal hickeys back there, but nothing explaining his vision loss. Says maybe you've had an old non-arteritic and ischemic optic neuropathy, and the retina specialist refers the patient to me for a neuro-op evaluation. So the first thing we want to do is what hasn't been done in a visual field hasn't been done yet. The first thing I run is that. And again, for neuro-op, please stay away from the pattern deviations. Look at the grayscale. This is a person who's got a right incongruous hemiopic defect. This tells me he's got intracranial disease. We need to start looking further. So this is a person who's going to need an MRI of the brain with and without gadolinium, paying attention to the visual pathway. So we order it, and here's what comes back. He has got a suprasellar lobulated cystic lesion, pretty large, exerting mass effect in the left optic pathway, left medial temporal lobe structure, cerebral peduncle, left lateral and third ventricles. Very important, there's also a 4 millimeter left to right midline shift. I will tell you that once you start getting to 5 millimeter midline shift, you're looking at a potential fatal seizure. So this is an urgent situation. Now, most suggestive of suprasellar arachnoid cyst. Now, when ordering imaging, we are responsible for what comes back. The neuroradiologist doesn't call the patient. I can tell you if a neuroradiologist calls you, it's something bad. So this is one that now it is my responsibility to work out with him, and I've got to find. And I will tell you, I had a hard time finding a neurosurgeon who was willing to take on the case. He told me he went to one of my referral neurosurgeons where he felt the doctor was dismissive of him, said he can't help, you need to go to a university, find help elsewhere. So I kept working through my referral sources, trying to find a neurosurgeon who would take this on. Now, interestingly, I only saw the patient one time, Greg, but it seemed like I knew him a lot more because I was talking to him frequently and trying to get him the proper care. And the challenge was our conversations always devolved. And what they devolved was he understood he had a mass in his brain, but it would always devolve down, but I had cataract surgery. I should be able to see better. And I had to redirect them toward this. Now, this is one of those things I had on a yellow sticky pad to follow up with him. I was about to give him a call, and I got a card in the mail from his housemate who thanked me for helping him get care. He did get a surgeon to remove the mass, and about a month afterwards, he passed away. And the card said he passed away from numerous variables and conditions after surgery. It didn't say complications. My belief was, from what I read into it and something I followed up online, is most likely it was suicide. 33-year-old male. Listen, I'm going to do a couple of these rapid fire because it all comes down to a theme. He's got occipital headaches for about 4 months, and he occasionally gets a visual aura with his headache. It worsens when he stands after sitting. It's relieved by sleep. He's a dental student. He's in class all day. He stands up after sitting down, his headache worsens. It's kind of chronic and daily. No vision loss, no nausea, no double vision, no pain in eye movement, no behavioral changes. He goes to an internist for an age-appropriate physical examination and then referred by his PCP, as a headache person, said, get your eyes examined to make sure it's not your eyes. So I see the patient. He's 20/20, a little bit of myopic correction. Pupils, EOMs, confrontation fields are normal. Biomicroscopy normal. Pressure's normal. Nerves are normal, just nasally obliquely inserted with a 0.3 CD ratio on each eye. And here's his visual field. So here's a person with a chronic headache, daily headache, otherwise healthy, does change with posture. So I work with the internist, and we decided to do a blood panel that's a little bit more extensive, looking for infectious diseases, infiltrative diseases, malignant diseases. And of course, we said, well, he does have headache. We'd be crazy to do all this without getting an MRI, which we did. And this is not him, but this is very representative. He had a very, very large mass. It was in the frontal parietal region, more towards his right side. Lesions in the parietal lobe tend to give visual auras. So this is a person who was having midline shift, again, at risk of dying from seizures. So my colleague, the internist, tracked him down, got him admitted to the hospital, put on anti-seizure medicines, Diamox and steroids. Ultimately, he underwent a craniotomy, had it removed. He went back to dental school. He graduated. He started practice. But I wanted to follow up on him one time, and I reached out. I did a Google search, and it popped up a link to his obituary. He died 5 years later from brain cancer. Now, here's another slide for you all to remember. A normal visual field doesn't mean that there isn't anything wrong. It just means that the visual system is not impacted. A clean visual field does not mean there's no disease. 39-year-old male, COVID lockdown, has a history of migraine. He develops lethargy and a new worsening headache. He goes to an ER where they admit him. They do a non-contrast enhanced CT of the head, MRI of the head, both interpreted as normal. He was in for 3 days. His evaluation was negative. His headache was attributed to migraine, although he was already a migrainer, and was given a new migraine medicine and discharged. 3 days after discharge, he develops horizontal and vertical diplopia. And this is what he looks like. We can see he's got a partial ptosis. He has an abduction deficit. He has an adduction deficit. Now, this was one of my former residents who reached out for help. I said, go and film his motility for me and let me take a look. So you got a partial ptosis. He doesn't adduct or abduct that eye very well. And there's some elevation deficits. Now, I had to ask to be filmed again because it looks like he's playing with a cat toy here. It's not giving my nice physiologic H. Now it's kind of looking up and down, it seems like, but he's got normal visual fields. I said we got to get a visual field. His acuity is normal. He's got a right pupil sparing partial third nerve palsy, a right sixth nerve palsy, worsening headache, and lethargy. So where's the lesion? That is either localizing to posterior orbit or cavernous sinus. We need to contact the radiologist for a second reading. The radiologist looks, we tell him, look at the cavernous sinus and posterior orbit. Radiologist from the hospital looks and said, no, cavernous sinus, posterior orbit is pristine. However, his pituitary gland seems a little bit chubby. And at this point, we knew what the diagnosis was. Get him back into the ER, tell him that he needs an MRI of the cellar and paracellar area, looking for a pituitary apoplexy. And that's exactly what he had. He had a pituitary macroadenoma that had bled and expanded like a blood balloon. It spread into the right cavernous sinus. It was spreading into the left cavernous sinus, but there's no mass effect on the chiasm or prechiasmal part of the optic nerve. That's why his fields and his acuity was normal. He was immediately admitted for an endocrinological and neurosurgical evaluation.
Hey, Joe.
Now, yeah.
I am going to head over and open up the other room. Are you able to see the chat box?
I can. I'll probably get it at the end, though.
I was just wondering if you could see the link that I put in there for the attendees to click to
I
migrate
will
over?
take a look. Yes, I do.
Okay.
It
I'm
came
going
at
to go over and
8:43
open that up and
p.m.
get our speaker set. So,
Sounds great. And Greg, can you repost the handout one more time?
yeah, I think what has
Before-
happened, I've been chatting with people behind the scene. People aren't getting it. It will be in the post-event email that comes out with the survey. The handout will be in there. I think what you'd have to do is log in and log out, and then I could repost it, but there's no reason to do that since the handout will be in the post-event email. I've
All right, Greg.
posted it about 4 or 5 times, and some people are messaging me behind the scene here, not getting it. I think because I turned on the chat box after people logged in. So,
Okay. All right, Greg, if
okay.
you open up for Steve, I think some of our audience will be there shortly, and I'll be wrapping up in the next 15 minutes.
Okay. See you over the other side.
Peace and love. All right, so what is a pituitary apoplexy? All right, it's a severe and potentially fatal condition happening in about 10% of all pituitary adenomas. And keep in mind, it may not be a known adenoma. People can have silent adenomas and they can live and die without ever knowing that they have this condition. But this is a sudden bleed into it and explodes like a blood balloon. They have headache, vomiting, can have visual impairment, ophthalmoparesis, altered mental state, altered consciousness, lethargy. It all comes from a panhypopituitarism. This hemodynamic instability comes from no adrenocorticotrophine hormone, and this can be fatal. This occurs due to a rapid expansion, usually by a hemorrhage or an infarct, of a pre-existing, though it may be an unknown, pituitary adenoma. Cranial nerve palsies can be common. Visual field defects can be common, and these are generally bitemporal defects. So a sudden onset of a bitemporal defect with severe headache, we're considering a potentially fatal condition called a pituitary apoplexy. Now, this is our normal sella turcica and our sellar region. Above it is the optic chiasm, and on each side we have the cavernous sinus, which has cranial nerve 3, cranial nerve 6, cranial nerve 4, internal carotid artery, V1, V2. Now, as this tumor, which may develop here, as it bleeds and expands like a blood balloon, often it moves superiorly and comes in contact with a chiasm. There is your bitemporal defect happening suddenly. Or it can spread laterally in the cavernous sinus. In this case, which is what it did, with 3, 4, and 6 being at risk, internal carotid compression. Or it can go both directions, where it can have ophthalmoparesis and visual field loss. So this is a pre-existing pituitary tumor that bleeds and expands like a blood balloon. Most common symptom, 90% of patients, sudden onset of severe headache, usually frontal or retroorbital, and these are overlooked as the potential thunderclap pain because in the ER, they're looking for subarachnoid hemorrhage, venous sinus thrombosis, cervical artery dissection. This is not high on the list of differential diagnosis of bad headache. So often the proper imaging is not done for these patients. About half the patients will have visual abnormalities. They can have visual field defects, bitemporal defect. They can have cranial neuropathies, facial weakness. In the ER, in this situation, when the patient comes in with the debilitating or severe headache, most will undergo a non-contrast enhanced CT because they're looking for acute intracranial hemorrhage. Now, acute infarct may be seen on a CT in these patients, but if it's not a hemorrhagic infarct, it's not going to show up unless there's contrast done. Really, MRI with contrast to the sellar parasellar area is most effective in imaging cases of suspected pituitary apoplexy. And the MRI is better than CT. So what happened in this situation? Well, first off, they had 2 images, a CT and an MRI, which were non-directed. They are not contrast enhanced. And actually evolved over time. Now, there's a good outcome in most cases. These patients can die. They can expire, but there's a positive outcome really in most of these cases. Usually, they're going to be started on conservative medical treatment to replace the missing hormones. If there is neuroophthalmic issues such as visual field loss, vision loss, ophthalmoparesis, and double vision, they're ultimately going to undergo a surgical decompression of the tumor and the hemorrhage. And they usually go through the sphenoid sinus. This patient, this all occurred during COVID lockdown, so nobody wanted to do any medical care that wasn't absolutely necessary. He got diagnosed with the proper imaging. He was stabilized medically and chronologically, and surgery was delayed because of the COVID lockdown. Once COVID lockdown was lifted, he underwent a successful transsphenoidal resection of the tumor and is doing quite well today. Now, the last one in my rapid fire series, here's a 46-year-old female. She's referred from a local optometrist, one of my former residents, for a new or sudden onset blurred vision of 1 month duration. She's got no pain, and she says she's missing a piece of her vision. Not very specific. She has no double vision. She's got no head pain. She feels she might have had a COVID infection a week before her vision loss, but she didn't test, so she doesn't know. She is on omeprazole for heartburn, and she just has this unspecified vision loss. Now, she also mentioned left side head trauma from a year before, which I don't think was contributory. She noted her vision loss pretty suddenly a month ago and feels like it's getting progressively worse. She's got no pain in eye movements. She's correctable pinhole to 20/60 in the right eye, 20/20. She's got an afferent defect. Her cupping is 6/6 in right and left eye. She's obliquely inserted nerves, so no pallor or edema. Color is mildly depressed in the right eye. It's normal in the left eye. Fundus and macula normal in both eyes. And this is what she looks like. Fairly large nerves, fairly moderate cupping. This is not temporal pallor. She has obliquely inserted nerves. We can see on the OCT, she's got a really pristine nerve fiber layer and ganglion cell complex. And we see she's got a normal visual field in the left eye, and she has an inferior defect, somewhat arcuate, though a little heavier emphasis here on the inferior temporal region. So that brings me to a polling question. I'm going to see if I can do it myself. If not, we're going to, okay. So this is, what is her likely diagnosis? Does she have optic neuritis, neuromyelitis optica spectrum disorder, myelin oligodendrocyte glycoprotein antibody disease, non-arteritic anterior ischemic optic neuropathy? Does she have infection, or does she have infiltration? Excellent. Give everybody just a few seconds. We're going to finish up in about the next 6 minutes. Everybody's doing great. Okay, I'm going to end the poll. Going to share the results. We have a pretty good smattering all the way across. The most common one is non-arteritic ischemic neuropathy. I can see where that would be a good diagnosis, but her cupping is a little bit large for that. Optic neuritis, she doesn't have any pain and eye movement, and it's a tough one because I really didn't give you what actually happened here. Let's take a second look. She's got this painless loss of vision, which she feels progressive over the last month. And the painless loss really made me go back to the history. And when we talked about it, she acknowledged that, she's a where she said she felt she was having trouble with her contact lens in the right eye and kept replacing it and felt it was a contact lens refractive issue. And I didn't put words in her mouth or force the history. She acknowledged that maybe the vision loss has been longer than the past month. And, I thought it was a contact lens problem. So I'm really not quite sure. So this is what we're going to need. We're going to need to do imaging of the brain orbits with and without contrast. Please rule out demyelination, compression, infiltration. She has a right optic neuropathy. Perform studies with and without contrast. And ultimately what happened was she did have a mass affecting the chiasm. And it looked like it was a planum sphenoidal meningioma. So this was actually not so much sudden loss of vision as it was a sudden awareness of loss of vision. And these are very frontal tumors that will grow. They can affect the frontal lobe and thus affect the patient's personality, and can actually affect the chiasm and optic nerve, which is what was happening to this young woman. So these are meningiomas from the midline cranial anterior cranial fossa. They're planum sphenoidal or olfactory groove meningioma. These are about 10% of all intracranial meningiomas. Because it does come very close to the frontal lobe, they can have cognitive dysfunctions or vision loss later on. And they can cause displacement of the frontal lobe and compression of the optic chiasm. These are most commonly treated with surgery. Now, as I said, when we do this and we diagnose these patients, and we are responsible to make sure they get the proper care. Now, ultimately, she underwent a craniotomy about 4 months after diagnosis. It really took that long to get her into the right place. My local orbital surgeon and neurosurgeons passed on this because of the chiasmal involvement and the proximity to the internal carotid artery. They felt uncomfortable doing it, but they fortunately did refer me to or recommend a skull-based surgeon at a university in Tampa. He did the procedure. He found the tumor tightly wrapped around the optic nerve. He said he had to leave a bit of the tumor. He said it was going to grow and it was going to cross over and he was going to blind her in both eyes if it wasn't ultimately addressed. Now, I saw the patient. I've only seen her twice. I saw her in diagnosis and I saw her in follow-up. She comes back and she feels that her vision is better. There's no APD at this point. And she's actually back down to 20/15 in each eye. And this was her initial visual field. We can see that there was loss of function. After surgery, this is her visual field. Her acuity and her visual field all improved dramatically. And to be honest with you, I was expecting this to happen because of this. She had normal structure. The structure was not compromised yet. And I felt, and I was right, that this could be addressed. I felt there would be some improvement, and there was. The fact that the structure was not affected is why she recovered. So I'm going to wrap up right here with what I call my summary. I just give you 5 mass lesions, right? Brain tumors or similar masses. Here's what I want you to realize. Visual is normal in 4 cases, abnormal in 1 person. Visual field loss in 2 cases. 2 cases had normal fields. 1 case had unilateral loss. There is headache in 2 cases. No headache in 3 cases. Diplopia and ophthalmoparesis in 1 case. None in 4 cases. No disc pallor in any case. No disc edema in any case. Conclusion: mass lesions don't follow any rules. They don't come screaming at you with headache, vomiting, and papilledema. We have to be willing to get involved and look at these patients. So I'm just going to jump ahead and wrap up because we're going to be very cognizant of your time. Come back and do these in the future. But this was our complimentary 1 hour Cranial Conundrums synchronous virtual webinar.